Hey, 𝗙𝗵𝗁 here, and today's video, what I want to talk about is 3 things that you can do. I always get that wrong. 3 things that you can do when extension-based back pain patients aren't responding to your traditional approaches. Okay, so you might have maybe moved the facet joints, or you might have done whatever you're doing. Okay, so here's 3 things that I want you to consider. Okay, so when the patient extends, okay, what we want to see is we want to see that hip coming forward. Okay, so very often what you'll find is if the hip isn't coming forward, okay, or the rib cage doesn't protract or come forward also, then very often the center of gravity comes back on the border of the base of support, and that causes then the facet joints to essentially go into end range very, very quickly. So we can undo that, or we can certainly get everything else to do its job so that the facet joints don't have to go to end range too quickly by making sure that these 3 tissues can lengthen. So the first thing that we want to see when someone goes to extend is we want to see as they lean back is we want to see the chest actually come forward. Okay, so when the chest comes forward, what needs to lengthen here is the actual serratus anterior. So you can see here, if you imagine here now, as this patient's going to extend, okay, as that patient extends, if we were to turn that animation vertically, okay, what you're going to see is as the patient extends is there's a massive lengthening. Look how big the serratus anterior is, okay? So as that patient goes to lean back, the shoulder blades are going to come back together, and look how much length you need through the serratus anterior, okay? So it's the ability of that serratus anterior to lengthen is going to be key to then allow that hip to come through, okay? Because if the rib cage comes forward, that's then going to drive the pelvis forward as well, which means then that we're going to actually use this movement here, and we're not going to end up in end range extension through the lumbar facets as quick, okay? So if we can get this to do its job, then very often the facet joint isn't going to have that end range too quickly, and then we'll change that pain experience quite quickly also, okay? So as I said, that lengthening ability is critical as that patient extends, okay? So again, if you imagine here, as they're going to lean back, the rib cage is going to go forward, you're going to need a lot of lengthening. Look how big that serratus is, okay? The second tissue is the internal obliques, okay? So again, it's not a great example here, but if you see the internal obliques, the way they're orientated, okay? So as that rib cage comes forward, those tissues are going to lengthen. Now, also what's going to happen is when the rib cage comes forward is we're going to go into an anterior tilt, okay? So with the anterior tilt, you're going to get a real big lengthening of that internal oblique as well, okay? So when the rib cage goes forward, okay, so if I just put it here, okay, if it's loading here, just give it a second, okay? So if I get the patient to, well, let's start here again, okay? So if I get the patient to extend, that rib cage is going to come forward, okay, to about there. So you can see that rib cage, that angle here at the bottom of the rib cage, the internal obliques are really going to lengthen as we extend, okay? So if we can get that diaphragm to contract well, obliques to lengthen, okay, then very often we'll take the extension based back pain away, okay? And then the third thing that I want you to consider is as we do that, if you recall what I said, when the rib cage goes forward and protracts, that's going to be coupled with an anterior tilt to the pelvis, okay? So what happens there is we need good load tolerance through the quads, okay, especially the proximal rec-fem, okay? So again, as that patient's going to extend, we're going to see then that we're going to need load tolerance through the proximal rec-fem. So if the patient isn't happy to tolerate load through the proximal rec-fem, very often clinically what I see happen is that they don't want to let the hips go forward, because that means they have to take load through it. So then they'll end up with this strategy, which will then contribute a lot towards the back pain, okay? So of course that's not all of the things that could be contributing to the back pain, but there are some of the top 3 things that I see clinically with a lot of these patients who have failed traditional approaches. Once we get these 3 things mobilizing, then very often that extension-based back pain will certainly disappear. Now remember, the key thing here with the patient is that when we do get that, got those tissues mobilizing, you will never ever be able to outrun the graded exposure. So we need to take that patient, then we need to load those tissues then through a graded exposure program, okay? So again, don't think that your job is done just because you've mobilized these tissues, okay? You'll never be able to outrun a graded exposure program, okay? So we need to bridge the gap from low to high level rehab to make sure that they get long lasting changes, okay? If that makes sense, just let me know. Just pop a yes makes sense in the comments. If you want more information on how the Go-To Therapist mentorship can help you with your complex patients, give you the confidence to treat any patient who comes through the door and keep them progressing without dropping off or cancelling or stagnating, just drop a yes please, can I have more information in the comments, and I'm more than happy to reach out to you and give you all of the information.